good evening. Great to virtually see lots of people again, and welcome to our updates and shared discussion group. I'm Sarah Benyon, I'm a consultant plastic surgeon and a divisional director at CUH. And tonight is about hoping to update as to what we've been up to really over the last 12 weeks at CUH since we last met, and where we are currently in terms of providing services for our patients. And tonight we hope to include a general overview, as well as some specific updates on outpatients and diagnostic services by Hugo Ford, surgical services by myself on behalf of James Wheeler, and emergency care by Stephen Wallace. And this is going to follow a similar format to last time. And I'm just going to check, it looks like we've got 40 participants, so I'm going to carry on and just start the meeting a bit at this point. So look, when we cast our eyes back to when we last met back in November, the feeling amongst us all was that we were remaining very, very focused on recovery. And sadly, as December unfolded for us all, the reality was really very different. And over December and January, we reconfigured the hospital and our workforce to cope with the surge in COVID activity and the increased demand on both critical care and medical beds. And Sue Broster, one of our deputy medical directors, in a moment will update on what was involved, both in terms of the escalation and also the de-escalation and the impact of this for our patients and our staff. We're now in the process of stepping this down and restoring our services and our teams, hopefully very carefully and very kindly. We're listening to all, and we're trying to be mindful of the impact of this on our patients and staff as we move forward over the next phase. And like last time, it'd be really helpful to hear from you all. The Q&A is very much open, and we look forward to answering as many questions as possible. And we welcome hearing from you all with regard to your experiences over the last few weeks of CUH, but also what you've been up to. Particularly, I know a lot of you have been embarking on the huge vaccination program, and the amount of that must be pretty hard work over the course of the last few months. So please feel free to feed back to us on that as well. And in terms of housekeeping, my understanding is the chat has been closed to channel everyone through the Q&A box on the side of your screen or at the top if you're on an iPad. Tonight, we're also going to run an exit survey for feedback from you all so that we can adapt and renew how we're doing this, and look forward to receiving this at the end with a view to maybe guiding our sort of future process. Before I hand over to Sue, I want to highlight we've got a number of other people from CUH tonight on Zoom who guided a lot of the work we've done both in the last few weeks, but also over the last year in terms of guiding our recovery and our restoration programme. We've got Andy Thornton, our ops manager, and Christoph Kastner, one of our consultant neurologists, who've really helped to focus the work on outpatients. We've also got Kerry Broom, who leads on planned care and electives, and we've got Vaz Ahmed, one of our ED consultants as well. We also have James Morrow, who probably needs no introduction, but as you know, he's been helping to frame some of the ways that CUH is working with primary care, and he'll also update on this tonight for us. So with that, I'm going to hand over to Sue now to update you on what we've been up to. And in a moment, Nikki's going to start the slide set, which we'll have up during the talk, and we'll stop at the end of the talk to allow time for us to see and answer questions. Thank you.
Thanks, Sarah, and welcome to everyone. I think we're just going to put the slides up and then I will talk to those. But a welcome to all of you, and thank you very much for giving up your evening to talk together. I think about it, there has been some really significant challenges over the last few months for everybody, whatever part of the NHS they've been working in. So I'm just going to give a bit of an overview about where we are and then how we work together as we move forward. Next slide. I think it's 2 slides forward for the first one. Thank you. So this is just a sort of overview if I think about the escalation, the de-escalation and the restoration. So over December and very much into January, there was a real urgent need to free up staff and also space to create red wards again with the second wave of COVID, particularly also respiratory support and a huge increase in our critical care up to 104 beds. And I'll talk about that in a bit more detail. what that meant was also it was really important for us to try and minimize the risk of infection to the patients in the hospital, but also in terms of keeping staff safe, both of which were extremely important. And the decisions around how we stepped up and how we're now stepping downwards have been very much driven by some data, which again, I will also share with you as we go through. So the decisions around how we did that, as I say, were led by data, but really also engaging with the clinical teams to really support that and really think about what did we keep going, how did we keep the maximum amount of activity going for patients who were non-COVID as well as those who are COVID. And that's been a priority all the way through, around maximising the care that we provide to patients across the board, and not just focusing on one patient group, because all the patients within that are important. So really thinking about how we treated as many patients as possible, but also recognising that we really did have to suspend and reduce some services, and the impact of that will have been felt for the patients, but of course we recognise that will have been felt in primary care. That also caused quite significant disruption to our teams, as many staff were redeployed across the trust to work in different areas. Examples of many staff being labelled as category B, so effectively healthcare assistants working in critical care to support the staffing numbers there. Many of those were non-nursing staff, a large number of medical staff, medical students and others stepped into those roles, for which we're very grateful. There was also changes to staffing ratios and other really significant changes that needed to be made. We're now in the position where we can start to de-escalate. The data, which is played out very widely in the media, shows that the numbers of cases of COVID are falling, and we're really now able to start to de-escalate and really look again at how we provide care for patients across the piece. Really focusing initially on the priority P2 patients, so those ones who are clinically urgent, and particularly those who are waiting for clinically urgent diagnostics and surgery, and then onto a broader range of clinically urgent case, but also thinking and taking a step back about how do we do things differently? Is there a space to do things differently, and how do we start to look at that and work in partnership with primary care around that? Next slide. Again, this just outlines some of what we said. So our peak across the hospital was 262 patients in the hospital. 60 of those were in critical care, but we increased the number of critical care beds up to 104. And that was because there was still a significant demand for critical care from non-COVID patients, which was incredibly important that we met for trauma, for neurosurgery, for some of the super specialist specialties that continue on site. So there was a combination of both of those. We also were a surge or super surge centre for critical care, and took in quite a significant number of patients from around the region to try and load level, so that we could try and keep patients safe across the whole region, and also out of region, supporting other areas that were at a higher level of COVID than we were at certain times. And that offer was also reciprocated out of regions where teams did that to support the East of England. So the numbers were significantly greater than in the first wave, where we sat at 134, and you can see that in the graphs that are well presented there. Next slide, please. So this really just describes a little bit more about the number of changes for staff, which I think I won't go into in huge detail, other than to say a large number of staff needed to be redeployed across the trust to really recognising the conversation I've just said about different areas changing from green to amber to red, some of the wards being created into ITU, theatres being created into ITU space to create this 104 critical care capacity, but also recognising the respiratory patients and others. And that required, as I say, lots of staff to move around, which meant stopping, pausing, stepping down other activity during that time period. Next slide, please. So I think this is really quite self-explanatory. It talks about the COVID data that's available to us. So on the screen, as I'm looking at it on the left-hand side, the daily COVID admissions and the 7-day rolling data show that that is significantly and quite rapidly falling. And if you look at our own internal data around our admissions, again, we look like we're mapping against or in fact a little bit more quickly potentially than the rate that we fell at on wave 1. So again, that's all quite positive as we think about how do we go into the next phase, but also remembering the importance of looking after the staff who have been redeployed, working differently, working additional and very different kind of ways of working over the last few months. And that will be no different, I suspect, from the pressures that primary care have felt around the demands on their time. Next slide, please. So again, this is just looking very specifically around patients in sort of general beds, if you like, general acute beds, and it would suggest that the activity is falling ahead of the trajectory, and again in the ITU beds, that the activity is falling again ahead of trajectory. And I think the next few weeks will be really critical as we start to see, we hope, and the evidence, early evidence would suggest the benefits of vaccination across the population. Next slide, please. This may be data that you've seen already or that you see regularly, and this just talks around the number of cases from the peak, sort of at the end of December, early January, for the activity across the region, across all ages and those over 60, and then the really rapid decline across those over the last few weeks by Cambridge, East Cambridgeshire and South Cambridgeshire. Next slide, please. So looking at this data today, the data that's on the slides was when the slides were prepared just a couple of days ago. So today we've got 9 patients in the red bed, so rapidly dropped down from the numbers we talked about in the peak earlier, and 13 in critical care. And as you can see, the R rate for us is 0.6 to 0.8, so slightly lower than the overall rate across England. But we've still got a significantly reduced bed pool compared to where we were pre-COVID, which does require us to think differently about how we work. Next slide, please. So our response overall to patients, so what have we continued and where have been the pressure points? And I'll be really interested in your perspective on all of this. So we've maintained emergency care for our tertiary and local patients, and that remains a priority, that's safe emergency care. Continue to provide paediatric and maternity services. We've continued with urgent P2 surgery, and that has been allocated through a clinically led group, the surgical prioritization group, which met every week to look at the most clinically urgent patients to ensure that they were prioritized for the significantly reduced theatre capacity that we had. We've really worked quite closely with the independent sector to try and maximize the potential and the workload through there for the most appropriate patients that could be seen in that environment. We've continued with the inpatient and outpatient urgent diagnostics and maintained the urgent outpatient appointments, but you'll see the impact that COVID has as we go through the following data in the slides. And we've really tried to maximize the off-site or mobile opportunities that there might be. Next slide, please. But despite all of that, and as I'm sure many of you will be aware, there have been an increase in wait times, both in those patients who are waiting for their first appointment, as is described here, as well as some of the waiting for treatment time. So we've seen an increase, and we recognise this will be extremely difficult for patients who are waiting to be seen, of wait times from 10 weeks up to 14 weeks for their first new outpatient appointments. And it's really critical for us that, and we really want to work with you on how we manage that expectations and how we can do that well with the patients who are waiting. So your perspectives and thoughts on that will be really well received this evening during the course of the next hour or so. Next slide, please. And again, we talked about this in the session in November, and the numbers were significantly smaller than they are now, and they've continued to really quite significantly rise over the last few weeks as the pressure has been absolutely huge across the hospital. And you'll see here that the data shows that that patients are waiting, some of them a really exceptionally long time for their treatment, and that time is increasing by around 2 weeks every month. And again, the same conversation stands about we need to be communicating that to the patients who are waiting. And some of that obviously is the responsibility for CUH to do that. But how do we do that well? What do you know about your patients that can make us do that better? Those would be really important things for us to hear about this evening. Next slide, please. And again, I think this just highlights it in really stark form, the real change over the last few months as we've seen the impact of the second wave of COVID. Next slide, please. I think this is something that you are also really well versed in, is around vaccinations. I know that many of you are directly involved in that in your GP primary care settings. So CUH will have start delivering the second doses the end of this week, and they will be delivered between the 5th of March and 30th of April, starting with the over 80s and then moving on to all staff, by which point at the 30th of April, we anticipate that all staff who had their first vaccination will have completed their second. You can see the numbers are quite significant, and I think that's a real testament to, again, all the volunteers, as well as occupational health and others who've been really closely involved in this, but a large number of volunteers, both staff in the hospital and also medical students, and many others have committed to delivering this. So over close to 24,000 individuals have been vaccinated on site, and around 91% of our staff have had their first vaccination. We have a small supply of the AZ vaccine. Predominantly, we're using Pfizer on site, and we are vaccinating some inpatients with this. And there's also the newly established, or establishing, the clinic for the highly allergic patients. And I know from talking to the team who are directly involved in that, there is a steady stream of conversations around those higher risk patients with that team specifically. The next step is to look at how we manage the pre-op and pre-immunosuppression sort of patient clinics, so moving into other groups. Next slide, please. And really the sort of final slide for me is just to talk about the ongoing staff testing. So this is a PCR-based testing program, which has been in place since last summer. There's around a 24-hour turnaround fairly consistently on that. There are generally, that is done weekly. There are small groups of highly vulnerable areas where staff are doing more frequent testing. I think what is really stand out is, and really positive news for the vaccination, which sits alongside this, and it's a comment there from Michael Weeks, who's been closely involved with the STARS testing program, is that the Pfizer vaccine, as he says, not only provides protection against becoming ill from COVID, but also helps prevent infection, reducing the potential for the virus to be passed on to others. And there was a fourfold difference in that between those who are unvaccinated and those 12 days post-vaccination. So I think that's a really positive note to end on in what has been an incredibly difficult time for both as I said, primary and also for secondary care over the last few months. Thank you.
Thanks, Sue, that's great. I'm just looking at the Q&A. There doesn't seem to be any questions yet. So I just think, just a comment really, in terms of, you know, if we go back to sort of slide 6, looking at the COVID bed occupancy and those trajectories, we were very lucky that we were supported so much by the modelling group, which have worked really closely with us over the last 12 months. But I think one of the real difficulties we struggled with within CUH was we saw the numbers rising, you know, from the middle of December. And it was so difficult to gauge what that rise would be, how that rise would be sustained, but also which trajectory we'd follow in the recovery period. And that's, you know, has been one of the difficulties in terms of planning with reconfiguration and, you know, redeployment of our staff. And I think, you know, that's the first point just to make, but also the surprise, I think, from myself and also some of our team as to how the trajectory has tracked along the lowest, you know, possible line really, and how well, you know, the de-escalation has been able to be because of this. And I guess, you know, and questions from, you know, to all really, why do we think that is? Do we think it's just the impact of the vaccination program? It's, you know, what do we think? I mean, Hugo, you're nodding. I think that probably is it. I'm a surgeon, I'm very simple, so that sort of makes me think that's probably the answer. But you know, I don't know if anyone else has any thoughts or sort of, you know, comments on that. Sue, if you've got any sort of comments on that to come back on.
I do think it's mostly the vaccine, Sarah. If you look at the shape of the curves from the first and the second peak, there was a sort of shoulder on the first one which carried on a bit, and we've really gone some more or less straight down. I think that is the vaccine effect of people getting, fewer people getting less ill in the second.
Yeah.
One.
I think it's probably I think the vaccinations probably played the majority of the role, but I think for sure there has been some benefit from the social distancing, from all the measures that have required people to stay at home over the last few months, and the combination of those different factors. And that's going to be, I think, for all of us, something that's really important. Although Michael Weekes' data is really very powerful, the vaccination has got a bit of a way to go. And as we start to make changes to how we live our lives, with changes to the government's sort of advice to all of us, the impact of that needs to be really carefully watched on how what we see coming into the hospital. The numbers are really very small now. Do we see that change? And if we do, how do we respond to that really quickly, so that we try and continue to provide care to the patients that need it?
Stephen and James, I think, James, you were first. So do you want to come in there, James?
Yeah, I mean, phenomenal figures, and thank you so much. I think I speak on behalf of everyone in the community when I say an enormous thank you to our colleagues in the Acute Trust who have borne the brunt of the really difficult care of so many very ill patients. And I just think it's a phenomenal achievement to expand critical care facilities as quickly and as rapidly as you have done. And it's only much appreciated by us in general practice, and I know by our patients, that actually the reassurance of having both CUH on our doorstep and Royal Papworth as well has been just a vast reassurance, comfort blanket for very many people. And I think I would agree, it's the vaccination programme is one of the major drivers in this rapid fall. And that again is, I think, demonstrated the value of collaborative working across, the CUH taking the first steps with Pfizer, the support from the CCG for primary care and PCNs and rolling it out, and the phenomenal efforts undertaken by CCS as well in developing the large vaccination centre. So I think it's a real triumph of collective endeavour, but it is just wanted to put on the record just how grateful we are to CUH and your colleagues for really what has been a really difficult time, and enormous thanks from general practice too for supporting us and our patients in that way.
Thank you.
Thank you, James. That's very kind. We'll make sure to get back.
Steve, did you want to come in at that point? Sorry, you had your hand up earlier, I know. So
it's hard to follow that, but to thank James for his thanks. I was just going to comment on the de-escalation, because I think another thing that we've done this time, which has made it simpler for us, is we're having had a much better understanding of the disease and its transmission, is we've been able to stand patients down from red wards a lot more quickly. So when we were winding down from the first surge, if you've been admitted and had COVID, we kept you in a COVID ward throughout the duration of your stay. Whereas this time we've understood that if you have recovered from COVID and 14 days have passed, it's safe to move you to green areas of the hospital, which means that we've been able to place those patients a lot more strategically, getting them back to green areas, or equally sometimes keeping them in red areas if that matches the most productive use of our beds. So we've lost fewer beds through the reconfiguration this time round than we did the first time, which has been an enormous help.
I guess one other question to us all really is also, obviously we know schools are going back on Monday, and we know that, we'll have Easter and we'll have April the 12th. That may well, I mean, actually Stephen and I were discussing this morning, what impact is that going to be, in terms of COVID activity, and, what do we need to plan for? Because obviously, one of the things that we are doing at the moment is planning so how we, de-escalate our red beds further, trying to create space for our elective capacity and our other medical patients. So I think it's a work in progress, but I think that is a little bit of a question for us all really, isn't it, in terms of what we feel the next 4 to 6 weeks will bring. And it would be great that the vaccination programme effect is maintained, but I do wonder what that will be. I don't know, Stephen, if you've got any more thoughts since we discussed it this morning, or if anyone else would like to come in at that point.
only staring into my crystal ball, I don't know. I think I'm anxious that, you know, we need to make sure that we've got enough flexibility that if numbers do plateau or blip a little bit, we've got a degree of resilience, because I don't think we've suppressed levels in the community to the same degree that we did the first time round. So we may see a slightly rockier exit from this lockdown, but obviously, you know, the good news is the evidence suggests that although the prevalence may be higher in the community because of vaccination, the number of people who are seriously ill requiring hospital treatment is vastly attenuated. So I think I've been learning through this period that I think, whereas I thought I was an optimist, I'm a closet pessimist. So I'm still thinking glass half empty, we need to be ready for the worst, but I'd like to hope for the best.
Okay, Jessica, you're desperate. Sorry, I didn't mean to miss you out then. So you come in there. We've also got a question now in the chat room, which we'll deal with afterwards as well.
So I just wanted to say, really, we're vaccinating 25,000 people a week at the moment. That's an amazing thing. If you think about it, a year ago, would we imagine that the NHS and Cambridgeshire and Peterborough could step up and do that? And we've done that as a system through the hospital hubs, but also through the vaccination sites and primarily through primary care. I think we've got a long way to go, and we have to be careful that people don't get complacent about social distancing. I am concerned, as you've mentioned, about schools going back, but we have come a really long way, and I think it's really good news.
Thank you. There's a question from Paula Newton, I think, which I recall, you know, a similar sort of theme last time, and in our last sort of GP updates back in November, and it's about prescribing. I don't know, Stephen or Hugo or Vaz, if you want to come in and answer that particular question. It's about how we, you know, often we're suggesting to primary care to prescribe medication which they may or may not be able to. And is there a way that we can help support that? Do any of you?
Sarah, I can answer.
Thanks, Christoph. Thank you.
Yeah, it's a question we get a lot, and in fact, Paula, you're totally right to question this. The current practice roots in a feeling of collaboration, which we started in May when we started our outpatient sustainability task force meetings. And in fact, we were drawn between trying to keep patients off site and minimizing the footfall in outpatients. And as you may know, the pharmacy in outpatients is right at the entrance, and there were massive queues, and we had to move these patients away from the building. And at the same time, we were obviously all doing remote consultations, which is quite difficult to then not bring patients in for pharmacy. So in these meetings, it came to an agreement that we're all collaborating. Addenbrooke's has increased very significantly, and I would have to lie to be precise, but it's in the area of 6 to 8 times increased the courier service for pharmacies for drugs being taken out into the community. So we're using that. We're using prescriptions being sent to patients, but in particular with remote consultations, it is quite difficult to actually provide medications. As you may know, technically, Addenbrooke's or hospitals nationally cannot prescribe directly to pharmacies, and FP10s are only available in clinics, if at all. And many of us are having to do our clinics from home, where we don't have access to these FP10s. So we came to an agreement that if GPs could help us with prescribing, we will obviously do our side, and we have done. And as part of all of this, we have also tried to make an effort at helping GPs with the phlebotomy and off-site imaging. So this is the background, and it's a question to help us. It's not going to be forever, I can promise you that, but at the moment it would really help us. We're trying everything we can. But it's a difficult task. We need to keep patients off-site. Sorry for the.
There's some very valid points there. For example, around specialist medication. I think we shouldn't be asking GPs to initiate a prescription of a only medication. I think that's absolutely clear, and we can take that back to pharmacy and try and communicate that out as well, because we do have ways in which we can manage that, as you said.
Thank you. Okay, in that case, I'm going to move us on to the next talk, which is on outpatients and diagnostic services, which is yourself, Hugo, and then we'll continue with questions afterwards. We're on slide 15. Thank you.
Thanks, Sarah. So Sue finished with the high points, so I'm going to start with one just to keep the mood going. So there have been some great successes, and actually the off-site drive-through phlebotomy at the Newmarket Road Park and Ride has been incredibly successful and popular with patients. This is something we set up because the on-site phlebotomy was, again, in a very cramped area in the outpatients and not capable of getting the patients through with social distancing. But we've now had over 20,000 patients through the off-site phlebotomy, and as I say, very popular with patients and clinicians. We think it's going to be something that's here to stay, and so we're looking at how we might be able to develop a sustainable off-site solution to phlebotomy. Next slide, please. So in terms of the referrals, after we reopened in June, we quite quickly got back up to the normal number of referrals that we'd been seeing before COVID. We did have, there is still a bit of a gap. So there's the people who were, as it were, not referred. We haven't seen a peak above that, and we assume that's partly due to pressure in general practice, partly due to patient choice and so on. But so we did get back up to pretty near 100% of our normal level of referrals. But obviously coming the second wave, it's dropped off again, and in January it was down to about 70%. Next slide, please. And so the difference between the second wave and the first wave really for outpatients was, on the positive side, we knew much better, how we were going to go about organising it, and managing the social distancing clinics and so on was much easier. People were much more accustomed to the non-face-to-face consultations. But on the downside, we had a significant number of staff from outpatients redeployed to the critical care areas, which we hadn't had in the first wave. So our actual on-site capacity dropped. So we did therefore see a drop of about 25% in activity. But as you can see, we've managed to increase our virtual proportion of virtual consultations now. Not as well as general practice, I have to say, but we're still improving significantly, and we're up to about 50% overall now of our consultations are non-face-to-face. Can I have the next slide? I think that's fine. And go on to the next one. So that's outpatients. In terms of diagnostics, there's been a pretty significant impact in some areas of the second wave. We've had to go through to only taking really emergency referrals for diagnostics. And you can see the impact there. And the result of that is our waiting list has gone up quite significantly. Before COVID, we had really very few people waiting over 6 weeks. Fewer than 1% of patients would wait over 6 weeks. And it's now nearly 10,000. So it's a very significant rise. Go to the next slide. And what you can see here is that there are basically sort of three areas. So we're going to talk about here. MRI has actually managed to maintain pretty good levels of activity. DEXA has been a real problem, and we're exploring whether the CCG can help us with opening a community DEXA capacity. Ultrasound had a big drop, but with insourcing and independent sector, we're sort of more or less on top of ultrasound. But CT is a very big problem, and even though we're only accepting urgent referrals, We have about, I think, 5,000 people waiting for a CT scan, and that's a very significant and challenging area for us for recovery. We do have another CT scanner opening in the near future, and we've been very lucky to have the CT scanner at Sawston, which is now working well. But that's of the diagnostic imaging modalities, that's our biggest concern. The next one, please. Endoscopy, again, almost closed completely at the beginning of January, other than emergency cases and interventional cases. Since we've been able to reopen, to redeploy, that's because most of the staff in endoscopy were redeployed to critical care. So we've now are redeploying them back, as you'll see later on the theatre plan, and that means that we've restarted activity in endoscopy to a more significant level, and I hope that fairly shortly we'll be back up to normal capacity for endoscopy. That'll still leave us with a significant waiting list to get through, but I think with insourcing weekends, hopefully we will be able to get that down. It came down very quickly when we reopened in June of last year. Next one, please. And this is the other area of concern, which is echocardiography. And this is not necessarily all about COVID, because there have been significant problems with staffing in other areas, but we do have a big problem and a big waiting list for echo as well. Next slide, please. And I think that just tells you what our current position is. So you can see that we're delivering sort of 80 or 90% of baseline in MRI and CT, but as already alluded to the backlogs, endoscopy will pick up more shortly. Next slide, please. And just a quick word on what that's meant for my other hat as an oncologist and the lead cancer clinician, what that means for cancer pathways. So we've managed to continue oncology services pretty well, so we don't have any significant delays for radiotherapy or chemotherapy, although we've obviously changed the outpatient service model a bit, and we've again had more off-site treatments. But as you can see, can I have the next slide, please? Actually, well, actually, if you go back to that one, you can see that the number of people waiting 31 days from decision to treat, that's the bottom right-hand graph, has gone up really quite significantly since January, and that is almost exclusively about the delays to surgery, which you'll see. Next slide, please. And this again just illustrates that another way. You'll see that basically the drop is almost exclusively in surgical activity. And I think we'll do one more. So this, well, it's another way of showing basically the drop in activity in cancer surgery. So I think they're going to talk about that in theatres as well. So you'll see, but the bottom line is in cancer, the main impact has been felt in surgery. That will be ramping up, I think, fairly shortly, as we'll discuss soon. And we will still have some waiting list issues there. Thanks, I think that's all.
Thanks, Hugo. Whilst you were talking, there were a couple of questions, and one of the questions was around when Suffolk GPs can start referring to dermatology services again. I don't know if Christoph or Andy want to comment on that, or you want me to?
I think it might be better for Carrie. Carrie, do you have something?
Yeah, I was actually just responding to that in the typing away, but prior to COVID in December 19, a decision was made in conjunction with the CCG and NHS England and Improvement following patient safety concerns raised by the Trust that we restricted the dermatology service down to our local catchment area. Obviously with COVID, we've not been able to review that for a reasonable amount of time now. We are continuing to ensure that we can accept those patients from our local catchment area, and that's open to some practices in Suffolk as well as in Cambridgeshire. we will review the situation. We are working on different innovative solutions. So we're looking at teledermatology. Within the trust, there's also a teledermatology pilot, I believe, being run by the CCG, and different ways to try and expand our capacity in dermatology. But until we've got a different solution and we've got a safe solution for our patients, we won't be able to review that, I'm afraid.
Thanks, Kerry. I mean, in terms of the teledermatology, obviously that was suspended briefly from January. I think it restarted on the 8th of February off the top of my head. But again, it's actually up and running at around about 75% of its pre-surge, sort of, you know, where it was in the autumn last year. And I think it's something that we probably do need to explore, upscale, and all of those things. And I know there's been previous questions as to how we upscale that and how that open that up to more primary care networks. And I think that that's probably something that will be part of the work moving forward that Erin and the South Alliance will be leading on. So I think, you know, that's something moving forward. There's one other thing that I heard from Sue earlier, and I don't know that we sort of, she made a request earlier about how we sort of communicate weights to patients. And I guess that's a question if people want to sort of discuss now, but also maybe in the chat, how we are communicating our weights to our patients, because I know that that must be very difficult when you're managing expectations of patients within primary care, particularly when you know that, you know, for both our routine and our urgent outpatients, the weights are growing for first appointment. So, you know, if there's, you know, people on the call that can help with that in terms of, you know, any suggestions, please feel free to comment and we'll pick those up as well, you know, and so forth. There's one other question, I think, just surrounding how an acknowledgement that the park and ride is clearly great, and I agree. I have to say, I think it's fantastic, and also, you know, the way we've managed to do that in a relatively short time frame. But again, one of the questions that is kind of a bit of a recurring theme is, you know, you guys receive a clinic letter from us with a long list of tasks, and it is incredibly daunting. And can we help with the forms in terms of radiology requests and blood tests? So I don't know if there's anyone want to sort of comment on that. I think some people do, and I know some of the neurology teams certainly are sort of very much engaged with that in terms of when they receive these referrals and they try and sort of help support that. Is it something that we're trying to?
We certainly could. There is a bit of a balance with the blood tests because you know, historically we haven't wanted to overload GP surgeries with doing blood tests. We're conscious that there's a significant workload there, but equally I can see that asking a GP to fill in the blood requests, it should be perfectly possible for us to do the forms. And that's something that we can again feed back in if that's something that would be helpful.
I think Hugo, it's probably a matter of culture. When you're doing a remote consultation with a patient on the phone, and you want to do a blood test, I think it's worthwhile asking the patient, are you able to attend the park and ride? And if they're not, I think that should prompt then a printout of a blood form when you're writing your letter. I think that should be possible. I think it's something to
communicate that out to requesters, can't we?
Yeah, exactly.
On what was the other question was about that you were talking about? Sorry, Sarah, about communication. Just so on cancer patients, so we've had quite a lot of discussion with our cancer patient group about how they want to be communicated with about these weights. What we basically, they get a letter which says something along the lines of, you know, you're on the waiting list. It may be longer than we would want, and we're very sorry about that, but you will not be forgotten. And then which is sort of what they wanted to know, I think. And then we're trying to make sure that people do get a follow-up just to ensure that they know that they're still in the system.
Yeah, no, I think that's good, and I know, you know, we've done this, you know, several times, communicating to patients that they are on the list, and we will get to them. I guess what might be quite helpful, and I don't know if we've managed it, if we sort of publish sort of time to first appointment, and I think Anna Wyatt's commented on this, whether or not we can, you know, pop that on the website, time to first appointment, RTT, all of those things for the different specialities. Kerry, are we working on that?
So we're writing to 3,500 patients a week on average at the moment, to let them know that that we haven't forgotten them, and that, you know, what to do if their condition's worsening while they're on the waiting list, and who to contact. We have updated the website. We've just Sue's actually just done a wonderful video for us that's also been translated into British Sign Language, and we've got a number of different languages on the website now, so patients can review that and see what they need to do. It's difficult from a first outpatient point because we've got so many subspecialties. We can say from a trust aggregate point of view it's 14 weeks, but in certain subspecialties we're waiting 40 or 50 weeks for a first outpatient appointment, and in other specialties and for 2-week waits, we're you know, patients are being seen within 2 weeks. So it's difficult to keep on top of that, but also difficult for the patients to understand which subspecialty that they potentially might have been referred to, if they think they've just been referred to gastroenterology, for example. So whilst we could publish this on the website, we certainly do publish on the website about the length of time and waiting times. But I think to narrow it down into a subspecialty, we could actually cause more confusion by narrowing it, by putting too much information on there at a subspecialty level. We can certainly look into it, publishing those first outpatient waits at an overall individual treatment function specialty, and see if we can get that data on there. I'm sure that's something we can look at, Ali, isn't it?
Yeah. Hello, I'm Ali Bailey. I'm Director of Communications. Yeah, I'm trying to help get these letters out. We can do all of that. Hello. I think we're kind of slightly waiting for the waiting times to stabilise a bit. I think that's one thing, and then we would have to get an awful lot of detail, and if we put that up, we need to make sure we're ready to update it, you know, weekly, so that it's accurate. So it's not that we're not looking at it, and I think we would like to do it as much as we can, and there might emerge, it'd be good to hear from GPs if there's a certain type of treatment like endoscopy, say, where it is particularly generating questions, where, you know, it would just be helpful and fairly straightforward to put that on the website, then we can perhaps do it that way, but perhaps not for every single subspecialty.
Can I just say, there's also a question on the web that's just come up on the Q&A about the waiting times being updated to GP Connect, and they are. So today I've sent out to our colleagues in the CCGs the length of time for waits, which I believe have sent out to all practices. So if that's not happening, it'd be really useful to know that if you're not getting that information, and then we can maybe tighten that link up to make sure that that does go in, and that is sent to you.
Thank you, that's very good. Thank you very much indeed. Okay, there's one more question. We'll have time for one more, and then we'll start, just so that we keep vaguely to time. There's a question here from Matthew, and it says the presenter would like to answer this question live. Is that correct, Nikki? Can we do that?
I can answer the question. Is that all right?
Good.
Sarah?
Okay.
Very good thought. You may imagine that we live in the 21st century. We don't. Even EPIC is very difficult to provide on the Park and Ride, and we do that in a very basic form. The TQuest forms have to be handwritten onto the bottles, and therefore converted into an official pathway. It is extremely difficult to get any digital information to the Park and Ride, and when we are establishing it eventually as a permanent one, I will promise you that we will provide it.
Okay, thank you. I think I'll... So do you want to say something, Hugo?
That's a big promise. There's an IT link.
Christoph makes good promises.
Could I just put in one request? I think I probably speak for many GPs, in that if patients do contact the trust, that they're not told to just get a letter from your GP to prioritise you. Those are not infrequent requests we get. We say people have rung out and been told, get your GP to write in to prioritise you. It results simply in a letter from the GP saying the patient tells me you've told them for me to write in to you, which adds no value. And I think, almost a plea to say, could the trust hold those difficult conversations with people saying there is a queue and you're in the right place in the queue, rather than bouncing back to primary care to field it, and those with the sharpest elbows and the quickest fingers on the keyboard bouncing the way up a priority list from those with the genuine highest need.
So
No, I think that's a very good point there, actually. And I guess sometimes it's also difficult in terms of where patients are directed when they call up, and it might be that they don't get the right information. And I think each department is different, and you're quite right. That's totally unhelpful, James. So I completely take that on board.
So James, if I can just add to that as well, with the harm review process, which we're just testing at the moment, and I know a couple of primary care colleagues are interested in supporting that, and we're just sort of finalising. We've just been doing a bit of a pilot to see how it works, but we've done a lot of work with one of the high volume specialties in orthopaedics, and the part of that work is the clinical teams at CUH having that direct contact with the patients themselves to understand exactly what the challenges are, and then for us to write and feed back to them what the next steps are, rather than trying to, clearly we need to make sure that the GP's primary care fully cited on those conversations, but not that they should be having to lead those conversations for the patients. We should be doing that work directly with them, and we're trying to just test out how we do that effectively and efficiently. So, but we'll continue to work on that and keep you in touch with that progress.
Great, thanks, Sue. That's really helpful.
Right, so we're going to move on to surgical services. So James, our DD for Division A, was unable to attend tonight. So if we just turn back the slides onto, I think it's slide 29 that we'll start on. So I look after quite a lot of surgeries. You're probably aware around about 60% of the surgical services lie within Division D. And I'm probably quite well placed to sort of update as to what's happened really over the last 12 weeks. And as you know, when we last met, so I think you're on the wrong slide. If we could just move forward to 29, that would be great. You're on cancer, so surgical services, that's lovely, thank you. When we last met, we'd actually managed to restore our theatre footprint and had returned to a near pre-COVID theatre schedule with Ely and the Cambridge Eye Unit up and running, and utilising the independent sector to reinforce this. And that's shown sort of later on slide 31, which we'll move on to in a second. One of the biggest difficulties we had at the beginning of January was that we walked into a very different scenario. And I know one of the questions on the last GP updates was, are we running sort of things like cataract mega clinics and mega theatre sessions? And we even managed to do that in December. We managed to run 2 or 3 of those, heavy cataract all days on Saturdays, and doing up to sort of 15, 16 cataracts a day. However, the beginning of January, as I said, was very, very different indeed. And as Sue has alluded to, the surge and creating 104 critical care beds, almost double what we usually provide, meant a significant redeployment of theatre staff, around about 93 theatre staff, to facilitate the increased critical care activity across several sites, including utilising our orthopaedic recovery and our theatres to look after our critical care patients, as well as freeing up the staff and the physical space to create red COVID medical wards, depleting the surgical wards substantially and the surgical team substantially to accommodate this, and also to provide enhanced respiratory support across some of these wards as well. And obviously this meant suspending many other services across elective surgery. Our focus, and if we just move forward to slide, I think 31 at this point, that would be really helpful. So this meant suspending 31, that'd be great, the next one, thank you. This meant suspending, a lot of services, but we really wanted to focus on maintaining a really good, safe emergency and urgent access to theatre. For those of you who may remember or don't know, we normally run around about 7.5 emergency theatres, but recognising that we had a real increase or at least a maintenance of our sort of major trauma work and neurosurgery work, we increased our sort of emergency and urgent access to around about sort of 11 and 12 theatres quite quickly, but then also managing to maintain access for P2 urgent cancer work in the remaining 3 or 4 elective theatres that we managed to maintain in the early sort of weeks and of January moving forward into February. The cases were allocated to these via the surgical prioritisation group, as we alluded to previously. And we set this up last April, and we've maintained it throughout the last 12 months. And actually, the format that we'd set up proved incredibly helpful to be able to really understand, you know, some of the requirements and some of the need for the various services, and just to try and understand and look at the impact and risk for these patients. We also managed to realign our independent sector theatres also to focus on our urgent and our P2 cancer work. And this proved incredibly helpful for many specialities, including things like breast surgery, which, as you probably know, operate mainly as day cases or 23-hour stays, urology, the melanoma work, and sentinel lymph node work that we do in plastics, some of the ENT work, and also some of the gynae-onc. And it worked incredibly well to be able to utilise this as a complementary sort of setup to our CUH footprint during that period. A lot of our surgical teams, you know, at all levels, supported critical care nursing, providing healthcare cover for shifts to help due to the increased demand, but also the nursing ratios that had to be, you know, altered as we were caring for a greater number of critical care patients, both from COVID and, you know, maintaining our other non-COVID critical care footprint, particularly as we are a major trauma centre. And I think you can see from slide 31, as we've, you know, de-escalated, we've reconfigured again. And certainly because of the speed at which we've been able to de-escalate, and you know, obviously the vaccination programme we talked about earlier is one of the contributing factors. As of next Monday, there is a significant increase in the elective theatre capacity planned at CUH, as well as this week we've reopened the Cambridge Eye unit. We're also planning on reopening Ely from around about the mid-March, I think 15th of April, or 15th of March we open there. Our focus has to remain very firmly on urgent activity and increasing our P2 surgery as much as possible. But we do remain very challenged in terms of the size of our P2 waiting list. You know, we've had conversations regionally and nationally exploring options for mutual aid for some of our time critical cancer patients. And we have utilised some of these pathways in colorectal amongst others. But unfortunately, some of our regional centres are in a similar sort of situation to us, for example, in neurosurgery, where we can't really exploit any mutual aid. So it is very difficult because they are either in a worse or a similar situation to us. So as we continue this and you know, as our COVID activity and capacity allows, obviously we'll prioritise the resumption of other services according to clinical urgency and what's practically possible. A lot of our plans really do revolve around good flow in the hospital and outside of the hospital so that we can maintain this activity. You know, it is challenging, and we understand the ask because of what we've sort of experienced over the last 12 months, and we'll just continue really just to work through this. There is talk, and you know, I think Steve may be alluding to some of the discussions about things like the Surge Centre, and one of the things we're looking at is whether or not there'll be any possibility of building extra capacity to help with some of our more not cancer surgery, but things like T&O and stuff like that, which we know that, you know, the waiting list is growing and it's very difficult for us to accommodate that. So one of the things that Division A and James are working through is what that can look like and how we can best manage our T&O waiting list. But yeah, I think at that point I'll stop and we'll answer any questions. So thank you. We'll go back into the So I'll open that up to questions. I can't see any on the Q&A in terms of surgery.
There's been a
Harry, do you want to come in?
Yeah, there was just one question around what a P2 was. So I've just explained that that's a category of prioritisation for patients that need to be treated within a month of being prioritised.
It's interesting, isn't it? Because when we first started, obviously if we track back to last March, none of this notation existed, and what happened quite quickly last April and May, where the colleges all came together to work out how we can classify patients in terms of their urgency and importance of getting surgery in a timely way. And the different specialities initially came up with quite wide-reaching ideas on this, and now we're fairly understanding of what that means. And you know, cancer surgery crosses mainly P2, but it also can be incorporated into P3 for some of the different subtypes of cancer. And I'm thinking about some of the urology cancers, Hugo, and you know, and so forth, and some of the colorectal as well. So yeah, absolutely, it's a notation. You know, it's something that we use, and that we're quite happy to use within the hospital now. But we also use it in outpatients, as Christoph has pointed out to me as well, obviously. And you may or may not know that we triage all our outpatients according to the urgency classification as well, which we all do very frequently in terms of our pre-outpatients review for our clinics at the moment. There's a question from someone about a queue number. They could track it. That would be very helpful. Is that possible? I don't know. I'm going to guess not really, because it's difficult at the moment in terms of managing what a queue means to people at the moment, isn't it? Because patients who are sitting in terms of less urgent, so our routine patients who are sitting in what we would deem as the P4 category, what that queue actually looks like is very difficult to determine. And I think, Sue, in terms of, you know, patients clicking over into waiting for more than 52 weeks, they will get a harm review, and that can involve sometimes a consultation discussion with the patient. I know sometimes it doesn't. That's probably as close to really what we're achieving there at the moment, isn't it?
Very difficult, because the problem with the P scoring is it's been very helpful in some ways, but it is a double-edged sword, because if you're, I mean, P1 means it's urgent, it's basically an emergency, and P2 is the ones, as we said, are to be done within a month. At the moment, the effect of everything that Sarah's just said is that we're really still only able to operate on P1 and P2 patients. And there are a huge number of patients who are P3 and P4, particularly P3, who have really quite significant, you know, symptoms or problems with their disease. So obviously it's prostate cancer, but a lot of orthopedics falls into that category. And if you gave them a queue number, all they would see would be people jumping in front of them the whole time. And I think that would be extremely difficult. So it is difficult. And what we need to do is to find a solution for actually getting those patients through the system, which at the moment we don't have.
No, I think that's actually a very good point, Hugo. And I think the difficulty is we have to prioritise patients in terms of urgency and, you know, cancer. And it will mean that a proportion of our patients who sit in P3 and P4 with time will gain increasing symptoms and disability, and will inevitably move into a higher P scoring. And I guess that's where us being very proactive in terms of harm reviews and keeping in touch with our patients will help. And at the moment, that's probably where we're sitting in terms of managing the queue. I think, you know, for now, I'm just looking at the questions as they're coming in. I don't think there's anything.
Well, Rich has asked a similar question, which is how much visibility patients have. The answer is they don't really have visibility of their position in the queue. They know that they're in a queue, but it's very difficult to get visibility of the position because the queues are, as we discussed, a bit of a moving feast.
Yeah, I think that's sort of a similar question to sort of what we've answered sort of earlier. Okay, all right. So I think at that point we will move on to Stephen, talking about urgent and emergency care.
I nearly fell into the most basic pitfall there of forgetting to take myself off mute, but I've cleared that hurdle. Good evening, everyone, and thanks for the opportunity to update everyone where we are with urgent and emergency care again. We're also lucky enough to have Vaz, one of the ED consultants, on the line as well. So this chart shows the sort of story of our unplanned emergency department attendances over the last year or so, which largely speaks for itself. We had an initial dramatic reduction in attendances during the outbreak of the pandemic last March. Which gradually lifted both during the pandemic, but then during sort of the plateau phase between lockdowns to around 300 attendances a day. Bearing in mind that during the sort of period in the run up to the pandemic, we were getting 350 to 370 on average a day. So it was a modest reduction, but back to sort of 80% of attendances. And again, when we broke that down into attendance types, the greatest reduction was in sort of the low acuity of patients rather than the major acuity patients like you might expect. The graph gets a little bit complicated on the right with the shaded in grey area, which is sort of an artifact of how we changed counting the patients attending the emergency department. But in effect, the line of patients attending the ED would be the top of the shaded in grey area. It did dip a little bit during December and has obviously reduced during this further lockdown, but not to the same depth that it did the first time round. And in many ways that's probably a good thing, because it means that people are still seeking the emergency care that they need rather than sitting at home and leading to delayed presentations that we experienced before. I was just looking at this in reference to the conversation earlier on around what may happen when schools reopen, and it does look like we did have a little upsurge in ED attendance back in late August, which I think probably does correlate with a bit more transmission, but we will see what the next few weeks bring. Cover the next slide, please. So, what have we been working on during the pandemic and then more recently? Well, anyone that's been to the Addenbrooke's emergency department knows that the estate is a long way from where we would want it to be. Our real challenge has been crowding. The physical department, we used to pretty much literally ram full of patients to make sure that everyone was seen in a timely fashion and accommodated. But with a highly transmissible pandemic, we've had to do a lot more social distancing and segregation. So we've been working to increase the ED footprint into neighbouring areas and developed a sort of a low acuity area in the minor injuries unit, and develop an expanded same-day emergency care area in what used to be one of our outpatient clinics, Clinic 5. That required fairly extensive estates work to make it fit for purpose, and that was completed just a couple of weeks ago. We've now got a very nice facility, which unfortunately I've not managed to put any pictures in the slide deck, but is a strong asset for managing patients through a non-bed base. And we know that if we move ambulatory patients to an ambulatory area, we actually have a much better chance of keeping them ambulatory and avoid sucking them into the black hole that is CUH. So hope that will impact our flow and occupancy issues in the wider organisation. Likewise, we've been developing pathways that operate external to the emergency department. So, for 10, 15 years, we very proudly run a single front door model of care where virtually the whole emergency take was funneled through the ED. And while that brought many benefits, it was already starting to cause us concerns with congestion and crowding, which were exacerbated. But we now have a medical red admissions ward, a green medical admissions ward, and a surgical assessment unit, all of which can take activity, either from the ambulances, GPs directly, or streamed from the emergency department. Again, sticking to the theme that getting patients to the right area at the right time is better for them and leads to less congestion in the emergency department. We've been working on alternative pathways, and Vaz, as I say, is on the call, has been instrumental at helping link our offering with the wider STP, and we've had some really positive pilots with NHS 111 where patients who are being validated actually get the opportunity for a virtual consultation that confirms do they need to come to the out of hours 111 service, and actually gives us the opportunity to book them into a timed slot, which again is good for them because they know when they will be treated, and it's good for us because it helps demand management. And we've also been doing pilots with minor injuries, having these virtual consultations as well to determine what is the best output for that patient. Is it something that needs to come to ED, the urgent treatment centre, or perhaps something that can be safely reviewed more routinely in primary care after the weekend, for instance. We when people get in the emergency department, we have segregated the department quite differently now, clearly with sort of COVID possible and non-COVID areas, and we're very dependent on that clinical triage for keeping our patients safe, but then have worked on rapid patient testing to help manage movement through the wider organisation. And clearly with such a transmissible virus, there are issues where those pathways have been challenged, and it would be wrong to say we haven't had instances where patients have been incorrectly placed while waiting for results, but actually we've been very successful generally at getting patients to the right areas and really minimizing nosocomial transmission. We have got a lot of challenges still. The biggest one by a long way has been outflow from the emergency department and very high levels of inpatient bed occupancy. As people have seen from the graphs earlier on, we've actually had to lose significant numbers of beds while converting wards to be read to accommodate the COVID patients. And obviously that whole cohort of patients, are patients that we wouldn't have been looking after before either. The other thing that we've really seen with the critical care surge is a drain on our staffing resource. And in many ways, our challenge is actually a story around the staffing. So looking after critical care patients requires one-to-one nursing, whereas our usual ward level ratios would be something like 1 nurse to 6 patients. So suddenly opening 50 extra critical care beds means that we're needing to pull staff from, yes, large as much as we could non-inpatient areas, but potentially up to 300 inpatient beds to open that 50 critical care beds, and that's caused us real challenges as well. And then we've got factors such as the staff isolating. So exit block, as the ED team call it, has been a real challenge. And I think the processes bypassing the emergency department have worked well. The timeliness of the ED review has generally been maintained until we find that the department is saturating, because we've not had the outflow to move patients onto their sort of destination on the wards. And we've been very well supported with the wider system, CPFT and the local authority on different discharge planning models during the pandemic, which has meant that we have managed to keep medically fit patients waiting in hospital for assessment as low as possible. As we sort of reach the next phase, we've got a degree of anxiety that we run the risk of those numbers increasing, which could impact flow more. The other challenges that we have had around the time it takes to do the get funding and do the estates work to optimise our pathways, and that's just sort of the reality of building in the NHS during a pandemic. And one of the pathways that I think has been disrupted more than any of us would want would be our mental health pathway, when patients are admitted to CUH, pending input from psychiatry and or moving to a mental health bed. We used to cohort them on our clinical decisions unit, which worked very well, but the reconfigurations in the department meant that that's currently being used for paediatrics. So we're tending to look after these patients on our short stay medical ward, but we continue to work with CPFT on optimising that pathway. If I have the next slide, please. So this is just some sort of stats and figures around what we have achieved. I think the sort of bottom left-hand graph shows where a patient presenting at the emergency department would have been seen last, I think it's January figures, compared to January this year. And you can see that the overwhelming majority were being seen in the main emergency department. We've actually now, reduced that significantly, so that, I think the numbers are on the left there, but, we were seeing 86% of people presenting at the ED in the ED. Now it's only 68% of adult patients who are seen in the main department. And this number also doesn't capture the number of patients that don't go anywhere near the emergency department at all and are being seen directly in same-day emergency care or other assessment areas. So actually the reduction is bigger than that data portrays. We are seeing the top right graph shows the change in presentation routes to the emergency department over the year. The biggest reduction, as I've alluded to already, is in self-referrals. We've got what we think is probably a slightly spurious reduction in GP and practice nurse referrals. People have sort of challenged that before, saying, does that mean GPs aren't seeing people and aren't sending them in? We think it probably means the exact opposite. Those are the patients that we are managing to target either to other services or get through to appropriate SDEC or assessment units without presenting at the emergency department. But the way we're capturing the data at the moment isn't fully recording that, so that's a work in progress. And then the bottom right charts show the impact that we've had on occupancy. The orange areas represent 2021 activity and the blue 2020. At the top graph shows all of our ED areas, including where we've spread out into neighbouring facilities, which shows a small reduction in total attendances that isn't dramatic. But then the bottom one shows the traditional ED footprint, which is now reserved for majors and resus, where we've very dramatically shifted the curve down, taking activity out. But the worry here for us and why the department still feels so very pressured is our sort of completely COVID secure safe level is an occupancy of around 44 patients, which is the dotted red line, and the solid orange line is our mean occupancy. So we're still finding late afternoon into the evenings that our mean number of patients is at the limit of what we can safely accommodate, and clearly if we have surges we're significantly above that. So we continue to really work on trying to make the pathways as efficient as possible. Have the next slide, please. So the story that is sad to have to discuss is the waits in the emergency department. We have seen with the sort of exit block and the challenges that we've had into the further organisation that waiting times have taken quite a significant hit over the last few weeks and months, and we are obviously continuing to provide a sort of acuity and urgency based service, but we are finding that the time once we finished assessing patients to sourcing a bed downstream in the hospital is increasing through this exit block. And we are occasionally now having patients waiting for very long periods of time after their assessments to get through to the inpatient bed. The waits for patients being discharged from the emergency department have increased as well. That's a slightly more complicated picture because your patients streamed to the urgent treatment centre GP services are actually seen very quickly, and that those figures are improving. But obviously the longer people spend in the department, the more likely it is they recover, and we may no longer need to admit them and discharge them, and they then obviously drag that mean upwards. And the graph on the right really underscores the fact that the real challenge driving these waits is flow into the wider organisation. Discharging people from hospital has become more complex because of COVID, the need of swabs before returning to places that have carers or residential care facilities. And transport for COVID patients is more complex, and all of that means that our discharge profile curve has been shifted to the right, whereas our aim is always to shift it to the left. And discharging patients in the morning makes an enormous difference in terms of moving people out of the emergency department, freeing the cubicle up for the next patient. But the silver lining and the good news for that story is we're now getting to the place where the wards are largely green again. We've reassembled teams that are better at functioning by the staff moving out of critical care back to their home teams, and there's a real concerted push on shifting that curve back to the left and freeing the beds up early in the day to support the pathways for patients that do need admission. Can I have the next slide, please? So what are we working on at the moment? Well, I've hinted at some of this already, and if not most of it, and broadly it's twofold, which is continuing to develop pathways that mean patients don't go near the emergency department if that's not the area of expertise that's required, and that's largely our diversion to same-day emergency care facilities, where we have this newly refurbished area largely used for medical patients at the moment, but we also have dedicated a ward as a surgical assessment unit, and that's working well. We want to continue strengthening our advice and guidance on the day for GPs. We've got several initiatives that work well, or we're told work well, such as Radar and the surgical consultants providing advice on their referral phone, and we're exploring the more generic GP liaison and advice for medical patients, and we've got a few pilots that will be enacting soon in that regard to see if we can improve the support we give you, which may mean that patients don't need to be referred, and then the pathways that direct into the UTC and NHS 111 rather than the main department. In the slightly more sort of medium to longer term, we're looking at strengthening our children's pathway and hoping to develop a children's observation same-day emergency care unit. I think we've been very lucky this year that paediatric demand has been low because of the shielding initiatives. We didn't see any of the sort of seasonal RSV surges that we would normally expect, but we're aware that leaves us in a very vulnerable position for next year, when potentially we've got 2 years worth of children who may all present that way. And indeed, you know, there's sort of signs in Australia and things like that they're having difficulties with that group. The last thing to finish on, in the keeping that everyone else has had of trying to finish on really positive news, if we have the next slide, is we are developing some more inpatient capacity, which is sort of funded through a combination of surge money and also money that we were working on before to develop a fire decamp program. But we're going to have wards T2 at U2 and U3 coming online this year. The first is T2, which is a 20-bedded, fairly bog standard, off-the-shelf ward that will enable us to move some medically fit patients who are awaiting complex discharge planning out of the core medical bed base to give us more capacity to treat patients. And then towards the latter part of this year, a more complex build will be undertaken, and you can see the sites there. Site A is where the T2, U2 and U3 are happening, just between the Frank Lee Centre and the ATC, but those 60 extra beds will give us medical capacity, which hopefully will mean that we can better protect and ring fence our other pathways. So, you know, every winter we would normally find an emergency medical activity, and obviously this year COVID surge compresses the bed base that we've got to run our elective surgical pathways through, which obviously drives waiting lists. With developing these facilities, we'll be able to cohort the medical patients, which protects the surgical beds, but also cohorted patients are managed much more effectively than if they're outliers on the surgical wards. And we should find ourselves in a bit of a virtuous cycle with improved flow. And then, you know, with better flow and more capacity, you know, that will mean that we can crack the exit block problem to improve the pathway through ED for those patients that do need admission. Thank you. Any questions about all of that?
That's great. There was a comment on there from Richard Brixey, Stephen, and I think it's you know, it's a important message in the system that the main impact on ED waiting is on outflow, not inappropriate attendance. And I think I don't know if you want to sort of comment on that.
I completely agree. I think, you know, the main challenge that we have at the moment is not the number of patients, it is not the timeliness of our treatment or our resuscitation of patients. It's when people are ready to leave the department, we're struggling to flow them into the rest of the organisation. Obviously, there are times that those things do become impacted, but, you know, we want to make sure that we get patients home as quickly as possible at the other end, because A, that's getting them to the right location for them and for their recovery, but B, it means that we can move people through out of the emergency department, keeping that resus bed free for the next patient that needs it. And I think, you know, the help that we need from you, and we need to develop the pathways for you to tap into, is really strengthening our offer. That means we can, I know it's cliched, but turn that sort of unplanned care into slightly planned care, where we can be sharing the risk and seeing the patient at 9 o'clock the next morning in a same-day emergency care fashion, rather than 9 o'clock at night in an ambulance with very little chance of turning them around and sending them home.
Yeah, I think you're right, and anything we can do to strengthen the pathways that prevent admission to hospital, for example, things like heart failure and stuff like that, and the long-term conditions that we're trying to work on, I think will reinforce that. And I think, you know, the last 12 weeks we've had the opposite of what good flow looks like, because we have had the wrong team, you know, being looked after by the wrong team in the wrong place, really, haven't we? And we've had to manage a surge with a full hospital, which is the opposite of what we were doing sort of last March, April, May, because we were managing to empty out the hospital. And Vaz, do you want to come in? I can see your hand up.
Yes, thank you. Thank you, Stephen. I think that's quite comprehensive, what you have just mentioned. Richard, I just wanted to pick up a point on, I know last time you said, can we book into, so I was just going to come back on that, because you said, can the GPs book into minors? So we have been working, we haven't forgotten about it. And the reason it's taking a bit of time is because there's some national IT issues which we are trying to sort through, where the GPs can book through the NHS 111 option 4 line for minor injuries especially. So we are looking into it. Hopefully we get a resolution by mid-March, end of March. The second bit, like you said, it is not the self-referrals. They are not inappropriate attendance. Cambridge GPs, and this is a return of compliment from James, have been excellent throughout the times, not just the pandemic, even before the pandemic. If you look at our GIRFT data, which is our getting it right first time, our patients come to us. There are less patients who don't see a healthcare professional who come to us than more. So the thing is that our GPs are seeing these patients. The second thing is that the self-referrals have reduced. It's a multifactorial reason for that. But one of the main reasons is the patients are able to right now speak to a GP. Before, they could not, and you have increased your capacity for us, which maximizes them not coming to us. So I think it's a very good position to be in. I know about other systems which are jealous at what we have right now. So thank you very much. And the last bit, which Stephen already mentioned, our biggest challenge is our admission capacity to meet the demand. And the thing is that it's not that we just don't have beds. It's just not, we don't have the beds at the right times. And that is what we are working on. And at some stage we can crack it. If we can crack it, we probably get some, like a prize for
Nobel Prize, I hope.
I was going to say Nobel Prize, but I think it's a prize we need to get, because no one in the country seems to have cracked it properly. So I think that's something we need to crack. Thank you.
There you go, Steve. That's something to work towards. Okay, and on that note, I think I will introduce James, who's going to discuss how we can move forward with primary and acute care as partners. And I think we're on slide 39, Nikki, to start that off with.
Great, thank you, Sarah. I will be brief. I'm aware that we're almost at the end of our allocated time, and colleagues have already given up a lot of their evening. COVID has necessarily imposed a dramatic change on how we have done things in primary care and in secondary care, and indeed in the interface. Before it all hit, we were working together in looking at new ways of doing things, of building relationships, of building pathways together, and improving the care for our patients. And I think one thing that's come through this evening is just how much we share those values around good patient care for the population that we serve. And I think this slide really is just talking to the fact that as we come out of COVID, as we start opening things up again, it would be a mistake simply to replicate what went before, and that actually we are all open across primary and secondary care to the opportunity to co-design between primary and secondary care with our patients, with the voluntary and charitable sector, new ways of doing things which address issues which were there before but have been brought to the fore through COVID. So we can move on to the next slide. The structural changes which are underpinning this, and may be an enabler, and I hope will be an enabler to this, is that the NHS is undergoing another reorganisation. There's a once in a decade all change. The system will change. The ICS, the Integrated Care System, will be the whole of Cambridgeshire and Peterborough. It will cover the footprint of the current CCG and STP. Within that, there will be two places, roughly the North and South Alliance. South Alliance is really the group of primary care networks who look towards Addenbrooke's as their primary point of referral of secondary and tertiary care provision. So we've got a real opportunity here within the place-based, the Integrated Care Partnership, the ICP, to really genuinely take hold of our shared patients, our shared agenda, a capitated budget for the total population we serve, and begin to design services that really meet the needs of patients. And the arrow on the right really sums it up, that we're going to start, the plan is to start with the individuals, with the patients, those we serve, and do everything as close to the patient as it makes reasonable, logical sense to do. So at practice level, self-help level, then practice level, then primary care network level, the integrated neighbourhood. Things should only go to the integrated care partnership, if you like, the South Alliance, when it cannot be done at integrated neighbourhood level. And things should only leave the ICP to move to the system level when we're unable to reasonably deal with it at ICP level. So I think this really is a mechanism. If we grasp this and take the opportunity, it is a way when we, across primary and secondary care together, can genuinely sit down and think, how can we make this better for ourselves, for our patients, for the community we serve? And I think this is the mechanism to do that. So that's really just the opportunity, I think, which is coming our way. This should be in place by April 2022 in a shadow form ahead of that, but a real opportunity for all of us collectively to put our heads together and to rebuild something that was better than it was beforehand, as one of the legacies of the COVID tragedy. So I'll stop there. Thank you.
Thank you very much. And I don't know, Erin, if at this point you want to come in and just talk about any sort of the discussions that you're sort of going to try and enter into over the course of the next few weeks in terms of sort of some roundtable discussions. Would that be a useful point to bring you in here?
Yeah, so I can touch on it really quickly. We are doing a bit of planning at the moment to do some discussions both with the South Alliance board next week, and then with the PCN clinical directors in a couple of sessions over the next few weeks. One with the PCN clinical directors, and we'll give you a bit of heads up so that you can get input from the GPs within your PCNs, and then one with CUH colleagues and PCN clinical directors to really take forward this work around the co-design piece that James was talking to, in terms of what do we think the priorities are in our part of the system, what can we best take forward together, and what can we look at changing and doing differently rather than just purely restarting what it looked like pre-COVID. So for the clinical directors who are on the call, keep an eye out for that. And if you're not a clinical director in your PCN, but you've got some stuff then that you would like us to take forward, then please feed that through to your clinical directors.
Thank you. And I think, key to that is just to hear from people as to what do they want, how can we work together, and what should we be working on, and ideas for that. And I think one of your exit questions from your from the survey for tonight is that, and it really is important that we do hear from people. And I think that's the whole idea of the roundtable discussions and starting off. So are there any other points that anyone else would like to bring up? Yeah, go for it.
Sorry, can I just add one point to that, though? If there are things that you want to raise with us directly as well, and this is the one last slide which will be in the pack, but we don't necessarily, please feel free to contact us via the Primary Care Liaison Office. Hopefully you all are familiar with them, but if not, then we will share that when we send the slide pack out. But please use them if you've got queries, concerns, if you want to flag things from a science perspective as well. Feel free to use that inbox and feed that through.
Yeah, because I think we're careful to avoid, we don't want to suggest initiatives which don't work and aren't applicable. It's about working together to identify and to co-produce things, isn't it? So that we can realize patients' expectations, but all practices' expectations and aspirations as well with this. Is there any comments from anyone else? I can't see any more questions. Yes, James, go for it.
I really just wanted to thank, on behalf of primary care, all our secondary care colleagues for giving up their evening and for the clear time and effort which has gone into pulling this together. It really is incredibly useful for us to understand, as users of the service and as referrers into the service, exactly the pressures that the service, the acute service, is facing, and the extraordinary efforts that you're going to rectify that. So just enormous thank you to all of our colleagues for their time this evening and for the effort that's gone into to bringing this to us. It really is very much appreciated. Thank you.
And thank you. And I think also, you know, from our perspective, you know, hearing from you guys as well is incredibly important to us. Particularly, I know you updated myself in terms of what you've managing to achieve with the vaccination programme and you know, over the last sort of 12 weeks as well. So I think, you know, keeping those conversations going are incredibly important. I've just noticed there's a couple of questions on which have just arisen. I think it's Alistair. Okay, thank you very much. That's very kind. I can't see any specific questions there. So if anyone thinks there are, please let me know. And otherwise, we will answer them all anyway, sort of after the session. I know there was obviously one that got missed last time by the suggestion from Paula at the beginning. So we'll try and make sure that we do keep abreast of answering the questions afterwards. And if there's anything, please email it and contact us. So yeah, thank you. Thank you all for giving up your evening. And I'm sorry we didn't quite keep to time. We've gone a bit over, but if there is, you know, just thank you very much, and we'll see you soon. And one of the questions is, when would you like to meet again? And we'll make sure that we respond to that and organise that over the course of the next few weeks to months. So thank you.